Imagine this scenario. You walk into the barn, ready for your morning check-in with your horse, and you realize something is just terribly wrong. There's no wet spot in the stall. Nothing. Or maybe just a tiny patch, far less than you'd normally see. That immediate wave of dread that washes over you. That's the kind of life-threatening puzzle we're going to try and unravel today.
Yeah, that sinking feeling is absolutely justified. What you're instinctively sensing there could be the signs of critical, urgent conditions we call anuria and oliguria in horses.
Anuria and Oliguria.
Okay. Right, and these aren't diseases themselves, but they're really alarming symptoms. They signal a profound, dangerous problem, either with the horse's kidney function or maybe a complete blockage somewhere in the urinary outflow.
So it leads to like a buildup of toxins.
Exactly. A rapid, toxic buildup of waste products in their system. It's an immediate emergency situation, and it really demands quick action.
Okay, so our mission then in this deep dive is to guide you through the complexities of these equine emergencies. We'll define exactly what anuria and oliguria mean in, well, measurable terms.
Yeah, the kind of precise numbers your vet is thinking about. Like anuria technically being less than 0.08 milliliters per kilogram per hour.
0.08, wow.
Yeah, tiny. And oliguria is less than 0.5 mil per kilo per hour. Compare that to a normal horse, which is usually putting out, 1 to 2 mils per kilo per hour.
That's a huge difference. But I guess for the owner listening, the main thing is noticing any drastic drop from what their horse normally does, right?
Absolutely. That observation is key. And then we'll unpack the three main categories of causes, we call them: pre-renal, renal, and post-renal. And you might actually be genuinely surprised by some of the common culprits. Things like medications we use pretty routinely, or even certain plant toxins.
Okay, and then we'll look at the signs.
Yeah, we'll explore the clinical signs, both the obvious and the subtle ones your horse might show, and then the systematic diagnostic approach vets use, including how something like a simple rectal palpation can give immediate, powerful insight.
Yes. And finally, the treatments, which I imagine have to be really specific.
Highly specific and urgent, depending entirely on the type of cause.
Okay. So by the end of this deep dive, you'll hopefully have a clear understanding of these critical equine emergencies, get the knowledge pretty quickly, and leave with some practical insights that could empower you to recognize these urgent signs and really appreciate the rapid, targeted intervention they demand.
Okay, let's unpack this.
Right. So to really grasp what we're up against, let's start with those precise definitions again,
Yeah.
because that precision is absolutely key in recognizing how severe these conditions are. As you mentioned, anuria is essentially the complete or near complete absence of urine production. Clinically, we measure that as less than 0.08 millikay Degger. It's a truly life-threatening state where basically nothing is coming out.
And oliguria? Oliguria, on the other hand, is a significant reduction, typically less than 0.5 milliliter. Both are way, way below what a healthy horse normally produces. Understanding these thresholds is sort of the first step in really grasping the severity of what's happening.
Okay, so when we talk about what causes these really dangerous drops in urine output, it seems like it boils down to three main categories, almost like different stages of a problem within the whole urinary system. The first one is what vets call pre-renal azotemia, right? And this is apparently the most common cause of oliguria. I kind of think of this as like a starved kidney.
That's actually a very helpful way to put it. It happens when the kidneys themselves are, initially anyway, quite healthy, but they're just not getting enough blood flow. We call that renal hyperperfusion.
So they're starved of the blood they need to filter properly.
Precisely. And the most common reasons for this are things like severe dehydration and hypovolemia, which just means the body doesn't have enough blood volume, usually due to significant fluid loss somewhere.
And that fluid loss could be from, well, simple things first.
Yeah, it could stem from something as simple as the horse just not drinking enough water. Maybe the water's frozen or unpalatable, or perhaps the horse is in so much pain from severe colic it just doesn't even think about drinking.
Makes sense.
Or it could be from excessive fluid loss happening elsewhere. Think severe diarrhea, profuse sweating from really hard exercise, or maybe heat stress, hemorrhage, of course, or even what we call third space fluid loss.
Third space.
Yeah, that's where fluid leaks out of the blood vessels into body cavities, like you might see with severe peritonitis. The fluid is still in the body, but it's not in circulation where it needs to be to perfuse the kidneys.
Gotcha. So it's not just about losing fluid directly out of the body then. Things like systemic shock that could do it too.
Absolutely. Systemic shock whether it's cardiogenic shock where the heart itself isn't pumping effectively, or maybe endotoxemic shock from severe infections like colitis, sepsis, or even a bad allergic reaction, anaphylaxis. All those can drastically cut down that vital blood flow to the kidneys.
It's all about a compromised supply line to the kidneys.
Exactly. That's pre-renal. Now, moving on to the second category, we have renal azotemia. This is about intrinsic kidney disease.
So the problem isn't the supply to the kidney, it's damage inside the kidney.
Right. Direct damage to the kidney tissue itself, which impairs its ability to filter blood and make urine. And this is where things can get, well, really fascinating, but often quite serious, because the kidney itself is directly under attack.
And this is often called acute kidney injury, or AKI, meaning sudden, severe damage, not just a temporary slowdown.
Yeah, it's the term, yes, AKI.
And what's really critical here, and maybe surprising for some listeners, is how common substances can actually be the culprits. Like nephrotoxins are a big one, aren't they?
They really are.
Think about NSAIDs, non-steroidal anti-inflammatory drugs, bute, Banamine, things people use a lot.
Exactly. If they're used at high doses or maybe for too long, and this is crucial especially when combined with dehydration, they can cause serious problems.
How so?
Well, they can inhibit something called renal prostaglandins. And these prostaglandins are absolutely vital for maintaining proper blood flow within the kidneys, particularly when the horse is already a bit dehydrated or stressed. Blocking them can lead to something quite severe called renal medullary crest necrosis.
Renal medullary crest necrosis.
That sounds bad.
It is. It's essentially a breakdown and death of the vital inner part of the kidney tissue, and often that damage is irreversible.
Wow. So common meds can be a risk. What else?
You've hit on a really crucial point about common medications, and it's not just NSAIDs. Another major group of nephrotoxins are the aminoglycoside antibiotics.
Like gentamicin?
Gentamicin, amikacin, yes. They accumulate directly in the kidney's filtering cells, the tubules, and they can cause what's called acute tubular necrosis, severe damage to those tubules.
And the risk goes up.
The risk dramatically increases with prolonged use, high doses, if the horse already has some underlying kidney issues, or, again, concurrent dehydration. It's a common theme.
Okay. What about things from the body itself? Good question. There are endogenous pigments, substances produced within the body, that become toxic to the kidneys when they're present in large amounts. Think hemoglobin from severe red maple toxicity, where red blood cells break down.
Oh, right.
Or myoglobin from severe tying up, exertional rhabdomyolysis. That muscle breakdown releases myoglobin, which hammers the kidneys.
So tying up can lead to kidney failure, too.
In severe cases, absolutely. And then you have other things, too. Heavy metals, certain plants like acorns, if ingested in large amounts, specific mycotoxins found in moldy feed, even vitamin D toxicity from oversupplementation can directly damage the kidneys.
So just to clarify, the kidney can also get damaged if that starved kidney situation, the pre-renal hypoperfusion, goes on for too long. It can turn into an actual damaged kidney process.
Precisely. Prolonged severe hypoperfusion can absolutely cause ischemic damage from lack of oxygen, turning a pre-renal issue into an intrinsic renal one.
And infections.
Infections, too. Leptospirosis is actually a reasonably common cause of AKI in horses, or even a systemic infection, sepsis, spreading to the kidneys.
Okay, so the pathways to kidney damage are pretty varied.
They are. And, while we're focused mainly on acute issues here, it's worth mentioning that end-stage chronic kidney disease can also eventually present as oliguria or anuria, as the kidneys just completely fail over time.
Right. So we've covered the starved kidney, the pre-renal, and the damaged kidney, the renal. That brings us to our third major piece of the puzzle. When the kidneys are actually working, they're making urine, but the urine simply can't get out of the body. It's like having a perfectly functioning tap, but the drain is completely blocked.
This is post-renal azotemia, right? Basically an obstruction.
Exactly, an obstructive uropathy. And the most common cause here, especially in male horses, is urolithiasis, urinary stones.
Stones getting stuck?
Yes.
Yeah.
These stones can become lodged in the urethra, particularly in geldings or stallions, due to the narrower passage, completely blocking urine flow. This is a surgical emergency because that blockage causes pressure to build up very quickly back towards the kidneys.
Can stones in the bladder cause it too? Less commonly, but yes. A very large stone sitting in the bladder itself can sometimes physically obstruct the opening to the urethra.
Okay, and here's another one that I think often catches owners totally by surprise. Bladder rupture.
Ah, yes.
This is most common in newborn foals, right? Often males, maybe due to straining during birth or some kind of trauma.
That's the classic scenario, yes.
Yeah.
But it absolutely can happen in adult horses too, say from severe trauma or even from a prolonged urethral obstruction that finally causes the bladder wall to give way and burst.
So when the bladder ruptures, what happens?
Well, the urine, instead of exiting the body, leaks directly into the abdominal cavity.
Hmm.
This leads to life-threatening azotemia, that toxin buildup, and severe electrolyte imbalances because the body starts reabsorbing waste products from the urine in the abdomen. It's a really dire situation.
Wow. Any other post-renal causes?
Less common things include urethral strictures, areas where the urethra has narrowed due to scarring or inflammation, or maybe masses like tumors or scar tissue, physically compressing the urethra or bladder neck.
And finally, something neurological.
Right. Neurogenic bladder dysfunction. This is when certain neurological conditions, think EHV1 myelitis, that neurological form of herpes virus, or even sorrel poisoning, affect the nerves controlling the bladder. The bladder can't empty properly.
So the horse looks like it's not urinating?
Exactly. They might appear anuric, but if you were to palpate or ultrasound, you'd find the bladder is actually hugely distended and full. It just physically can't contract and release the urine. It's like a communication breakdown between the brain and the bladder muscle.
Okay. So if your horse isn't urinating, or you suspect they aren't,
Right.
what are the actual signs you'll see beyond, the obvious lack of a wet spot in the stall, which is clearly a key observation for owners? What other, maybe more subtle clues might you pick up on?
Well, the signs often reflect that accumulation of uremic toxins and the fluid imbalances we've been talking about. You'll likely see depression and lethargy. The horse just seems incredibly dull, just not themselves at all.
Very flat. Anorexia, or at least a significantly reduced appetite, is a really prominent sign. A horse that normally dives into their feed might suddenly just be picking at it or completely refusing to eat. And as those toxins build up, you might even notice things like oral ulcers, painful little sores inside the mouth, or something called uremic breath.
Uremic breath, what's that like?
It has a distinct sort of ammonia-like smell. It's quite unpleasant and pretty indicative of severe kidney failure.
That sounds pretty distinctive, yeah,
Yeah.
and quite alarming. What about other systemic signs? Things that might be less specific to the mouth or breath?
You can definitely see colic or signs of abdominal discomfort. That could be either from the primary problem causing the issue, like a GI disease causing pre-renal failure, or sometimes the uremia itself affects gut motility and causes pain.
Okay.
Edema is another possibility, that's swelling, typically of the lower limbs, the brisket area, or under the belly. That can happen due to fluid retention when the kidneys aren't working.
But sometimes they're dehydrated. Exactly, it depends on the cause. Conversely, especially in pre-renal cases, you'll see those classic signs of dehydration like sunken eyes, maybe a prolonged skin tent where the skin stays pinched up after you pull it gently.
Right.
In severe cases, you can get cardiovascular compromise, maybe a real...
Okay, so you see some of these signs, maybe the lack of urine output, maybe the lethargy. You call the vet immediately. How do they actually figure out which type it is? Is it pre-renal, renal, or post-renal? Because as we've discussed, the treatment really seems to depend entirely on nailing down that underlying cause. This feels like a proper diagnostic puzzle.
It absolutely is a puzzle, and yeah, it starts with a really systematic diagnostic approach. First off, a detailed history from you, the owner, is paramount.
What kind of things?
Recent water intake, have you noticed them drinking less? Urination frequency, what's normal for them, and what have you seen lately? Any recent illnesses, like severe colic or bad diarrhea? Any drug administration, especially those NSIs or aminoglycosides we talked about. Any potential exposure to toxins, like maybe access to acorn pastures or red maple leaves. You are the first line of critical information.
Okay. So the history is vital. Then, obviously, the physical exam.
Exactly. The vet will do a thorough physical examination. Assessing hydration status is key. Checking that skin tint, looking at the mucous membranes, checking capillary refill time. This helps immediately start differentiating. Pre-renal cases are usually dehydrated, right? Whereas renal or post-renal cases might actually be normally hydrated or sometimes even overhydrated or fluid overloaded if they haven't been able to pee but fluids have been given.
Makes sense.
And here's where it gets really interesting, diagnostically speaking.
Yeah.
Rectal palpation. This can provide incredibly powerful insights right there on the spot.
How so? What can they feel?
The veterinarian can carefully palpate the kidneys, assessing them for size, for symmetry, checking if they feel painful when palpated. For instance, enlarged, painful kidneys can strongly suggest acute renal failure, that intrinsic damage.
Okay.
But what's often truly telling is palpating the bladder. If the bladder feels really distended, tight, and full in a horse that isn't urinating, that points very strongly towards a post-renal obstruction, like a stone, or perhaps that neurogenic bladder issue.
Ah, okay, so a full bladder means blockage or inability to empty.
Right. Whereas finding an empty or at least non-distended small bladder immediately suggests the problem is likely pre-renal, not enough fluid getting to the kidneys, or intrinsic renal failure, the kidneys themselves aren't making urine. This single finding can dramatically narrow down the possibilities and really guide the next diagnostic steps.
Wow, so that rectal palpation sounds like it can almost immediately tell a vet which major category they're likely dealing with. Differentiating between the starved or damaged kidney versus a physical blockage, it really narrows the focus, doesn't it?
It absolutely does. It's a cornerstone of the initial workup.
Okay, so after the physical and the rectal, what about lab work, blood tests?
Definitely. Serum biochemistry is vital. You'll almost certainly see azotemia, that's the elevated blood urea, nitrogen, BUN, and creatinine levels in the blood. This confirms that kidney function is impaired, but it doesn't tell you why on its own.
Just that there's a problem.
Exactly. Electrolytes are also extremely important to check. Hyperkalemia, which is a high potassium level, is a really common and potentially life-threatening imbalance in anuric or oliguric renal failure
Why is high potassium so dangerous?
because the kidneys are the primary way the body gets rid of excess potassium. When they fail, potassium builds up, and potassium is absolutely critical for the heart's normal electrical rhythm. Too much of it, severe hyperkalemia, can literally disrupt the heartbeat, causing arrhythmias or even cardiac arrest. It's a true emergency within the emergency.
Got it. Anything else specific in horse blood work?
Interestingly, horses with renal failure, unlike many other species, can uniquely develop hypercalcemia, which is an elevated calcium level. The reasons are complex, but it's another clue we look for.
Okay. And urinalysis. Assuming you can get a sample, that must be key too, right?
Yes, definitely. If urine can be collected, either by catching some midstream or more likely via catheterization, analyzing it is crucial. The urine-specific gravity, or USG, is a critical differentiator.
How does that help differentiate?
Well, in pre-renal cases, where the kidney is starved but still functional, it's desperately trying to conserve water. So the USG is usually concentrated, typically above 1.030. The urine is dense.
Trying to hold on to fluid.
Exactly. But with intrinsic renal failure, where the kidney tubules are damaged, they lose their ability to concentrate or dilute urine effectively. So the USG is often what we call isosthenuric.
Isosthenuric.
Yeah, it means the urine has roughly the same concentration as blood plasma, usually in the range of 1.008 to 1.014. It's basically unconcentrated. Seeing isosthenuric urine in a dehydrated horse is a very strong indicator of significant intrinsic kidney damage.
And in post-renal, the blockage cases.
In post-renal cases, the USG might actually be concentrated, similar to pre-renal, if the kidneys upstream of the blockage are still functioning normally. The urine itself is okay, it just can't get out.
Anything else in the urine sample?
We also look closely at the urine sediment under a microscope. Finding things called casts, which are like little molds of the damaged kidney tubules, strongly suggests intrinsic renal tubular damage.
Okay, so history, physical, rectal, blood work, urinalysis. Beyond those labs, are there other procedures that help really clinch the diagnosis?
Yes, a few key ones. Urinary catheterization is often essential. It does a few things. It definitively confirms if the horse is truly anuric or oliguric. You can actually treat the problem if it's a urethral obstruction by dislodging or bypassing a stone. And of course, it allows us to collect that crucial urine sample for analysis.
Makes sense. What about imaging?
Ultrasound is incredibly useful. We can do it both rectally to get a good look at the bladder and sometimes the kidneys, and also transabdominally, looking through the body wall. Ultrasound lets us visualize the kidneys, check their size, their shape, their internal architecture for signs of damage or swelling. We can also assess the bladder for distension, check for stones within the bladder, and look for dilated ureters, the tubes from the kidney to the bladder, which would indicate an obstruction further up.
And if you suspect that bladder rupture,
If bladder rupture is suspected, particularly in a foal, then abdominocentesis is the diagnostic test. That involves carefully inserting a needle into the abdominal cavity to collect a sample of the fluid that's accumulated there.
a belly tap.
Exactly. If the creatinine concentration in that abdominal fluid is significantly higher, typically more than twice as high as the creatinine concentration in the horse's blood, that's diagnostic for urine leaking into the abdomen, confirming a ruptured bladder. It's a very definitive test.
Okay. So once the vet has put all these puzzle pieces together and they have a clear diagnosis, pre-renal, renal, or post-renal, what's the treatment plan look like? I imagine it's got to be very specific to the cause, right? There's no single magic bullet here.
You've absolutely hit the nail on the head. Treatment is entirely dependent on the underlying cause. It has to be specific.
So let's start with pre-renal azotemia, the starved kidney. What's the focus there?
For pre-renal, the absolute cornerstone of treatment is aggressive fluid therapy. The goal is to correct the dehydration and hypovolemia, restore that blood volume, and get adequate blood flow back to those starved kidneys. We typically use intravenous crystallate fluids like lactated ringer solution or plasma-like.
Just pour the fluids in.
Well, aggressively but carefully. And critically, the primary underlying cause also needs to be addressed just as aggressively. So if it's severe colitis causing the dehydration, you treat the colitis. If it's hemorrhage, you stop the bleeding and potentially give blood transfusions. You have to treat the source of the fluid loss too.
And monitoring is key, I assume.
Continuous monitoring of hydration status, electrolytes, and, crucially, urine output is vital. And here's a really important point. Diuretics, drugs that make you urinate more, are not indicated, in fact they're contraindicated, until the horse is adequately rehydrated.
Why is that?
Because if you give a diuretic to a horse that's already dehydrated and hypovolemic, you risk making the dehydration even worse, further compromising kidney perfusion, and potentially pushing them from pre-renal into actual intrinsic renal damage. Get the volume back first, then consider diuretics if needed.
Okay, that makes sense. So what about treatment for intrinsic renal damage, that damaged kidney scenario?
Right. Here, the first step, if possible, is to remove or antagonize any potential nephrotoxins. So if the horse was on NSAIDs or aminoglycosides, you discontinue those immediately.
Stop the poison.
Essentially, yes. Again, aggressive fluid therapy is the primary treatment, just like in pre-renal, to support kidney perfusion and help flush out toxins. But here, because the kidney itself is the problem, we have to monitor urine output even more closely, often with an indwelling urinary catheter so we can measure it accurately hour by hour.
And if the urine output stays low even with fluids?
Then, once the horse is confirmed to be adequately hydrated, diuretics can be considered. Furosemide, also known as Lasix, is commonly used. It's a potent loop diuretic. But again, it must only be given after the horse is properly rehydrated.
Are there other options besides furosemide?
Sometimes mannitol, which is an osmotic diuretic, can be used. It works differently by drawing fluid into the kidney tubules. Historically, drugs like dopamine were sometimes used in an attempt to specifically improve renal blood flow, but its efficacy in horses with AKI is actually not consistently supported by evidence, so it's used less commonly now.
And what about those electrolyte issues, like the high potassium?
Ah, yes. Meticulous correction of electrolyte imbalances is critical, especially that potentially fatal hyperkalemia. We have several strategies for that, using agents like intravenous dextrose, sometimes with insulin, sodium bicarbonate, or calcium gluconate. Calcium doesn't lower the potassium, but it helps protect the heart muscle from its dangerous effects on the rhythm. It stabilizes those critical cardiac membranes.
Okay. And finally, what about the blocked outflow, the post-renal azotemia?
This category often requires immediate intervention to physically relieve the obstruction. That usually means attempting urinary catheterization first, to see if the catheter can bypass or push urethral stone back into the bladder, allowing urine to flow.
And if that doesn't work, or the stone is higher up?
If catheterization is unsuccessful, or if there are large stones in a bladder or higher up in the ureters, then surgery is often necessary to remove the obstruction.
And for bladder rupture, surgery is the only option?
For bladder rupture, surgical repair is absolutely essential, yes.
Yes.
There's really no way around it. The tear in the bladder needs to be surgically closed.
And fluids are still important here, too.
Oh, absolutely. Fluid therapy and electrolyte correction are also crucial in post-renal cases, especially with bladder rupture, where you have those significant electrolyte disturbances happening due to the urine leaking into the abdomen. Those need to be stabilized before, during, and after surgery.
What about the neurogenic bladder where the nerves aren't working?
If it's a neurogenic bladder issue, the primary focus is on treating the underlying neurological condition, if possible. We also need to manage the urine retention, often through repeated catheterization. Sometimes medications like bethanacol are used, which can help stimulate the bladder muscle to contract and empty.
Okay, so putting it all together, what's the prognosis generally like for a horse facing these conditions? It sounds incredibly serious across the board, and I imagine timing is just everything.
It really is. Overall, the prognosis is generally guarded to poor, unfortunately.
Yeah.
But it depends heavily on the specific underlying cause and absolutely, as you said, the speed of diagnosis and intervention.
So break it down by type. How does pre-renal fare?
For pre-renal causes, the prognosis is actually often excellent if it's diagnosed and corrected very early, before that prolonged lack of blood flow causes any permanent intrinsic kidney damage. If you catch it while it's just starvation and you fix the dehydration quickly, they bounce back very well.
That's good news. What about post-renal, the blockages?
For post-renal issues, the prognosis is also generally good if the obstruction is identified and relieved quickly. For instance, a successful urethral catheterization that gets urine flowing again, or a prompt and successful surgical repair of a ruptured bladder can lead to a good outcome, assuming complications are managed.
But I'm guessing the intrinsic renal damage, the AKI, is the trickiest one, the most uncertain outcome.
Indeed, intrinsic renal damage definitely carries the most guarded prognosis overall. If a horse is oliguric or completely anuric due to actual damage within the kidney, the prognosis is often quite grave, simply because the core filtering units of the kidney are damaged or destroyed.
Does the cause of the intrinsic damage matter for prognosis?
It can, yes. Nephrotoxin-induced cases can vary. For example, aminoglycoside toxicity, if detected very early, treatment is aggressive, can sometimes have a reasonable prognosis for recovery of function. But NSAID-induced renal failure, particularly that severe renal medullary crest necrosis we discussed earlier, often carries a poorer prognosis because that type of damage tends to be irreversible.
And chronic kidney disease presenting like this?
Chronic kidney disease that has progressed to its end stage, where the horse becomes oliguric or anuric, also carries a very poor to grave prognosis, unfortunately. At that point, there's just not enough functional kidney tissue left. Really, the longer the kidney function is severely compromised, the worse the overall outlook becomes.
So it really hammers home the point. Early diagnosis and truly aggressive intervention are absolutely critical for giving these horses the best possible chance at recovery.
Absolutely. One of the most positive prognostic indicators we look for is a rapid increase in urine output after starting fluid therapy, or in response to diuretics if they're used. Seeing that urine start to flow again is a huge relief and a very good sign. It truly highlights why immediate veterinary attention for any significant decrease in your horse's normal urine output is just non-negotiable. Your vigilance as an owner is absolutely key.
And that really brings us towards the end of our deep dive today into Anuria and Oliguria in horses. We've defined these critical conditions. We've explored the pretty intricate causes from that concept of the starved kidney and pre-renal to the damaged kidney and renal failure and the blocked outflow in post-renal issues.
We've also discussed the crucial diagnostic clues vets use, from history and physical exam findings like that key rectal palpation, to lab work like USG and electrolytes, and the highly specific, urgent treatments that each category demands.
Yeah, and it's become abundantly clear, I think, that early recognition by the owner and rapid aggressive intervention by the veterinarian are absolutely paramount for survival and recovery in horses facing these really challenging conditions.
Definitely. So maybe a final thought to leave you, the listener, with. Given how quickly these conditions can escalate and how surprisingly varied the underlying causes can be, what subtle shifts in your own horse's behavior or daily routine, maybe something beyond just the obvious absence of a wet spot in the stall? What subtle changes would make you instinctively realize something critical might be wrong with their fluid balance or their kidney function, enough to prompt that immediate call to your vet?
That's a great question.
And also, how does understanding these distinct categories of causes, the pre-renal, the renal, the post-renal, how does that change your perspective, perhaps, on seemingly unrelated symptoms, like how seriously you take a bout of severe diarrhea now knowing it could starve the kidneys? Or maybe how you think about the administration of certain common medications, especially in potentially risky situations. This knowledge really is what empowers that essential vigilance.